So it's,
They have a Facebook page too. All right. Oh, and some of those, the Savage Paramedic one will post like funny memes. Now that you guys are like getting the knowledge, you'll actually appreciate the humor behind. All right, gynecologic emergencies. Dun, 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 dun. Okay, right into the fun stuff. All right, everyone repeat after me. Vagina, clitoris, labia, perineum. All right, so get the giggles out. All right, so we use medical terminology, anatomical terminology when we refer to external or genitalia, male or female. So guys, this is the external makeup of females. So notice here, you do have a urethra here, the vaginal orifice is here, and then the anus is there. So again, this is another reason why women are more predisposed to UTIs of that close proximity. I have had several students in the past where were not aware of this at all before this chapter. Females have two different orifices, if you will. Okay, the urethra is one, and then the vaginal opening is another. They are not the same thing. So just so everyone's on the same page.
You said they didn't know?
No, and more than one was a female student. So just so you know, no judgment, but now you know the correct anatomical makeup of female genitalia. So again, guys, that perineum, what is that? When does that really come into play that can cause some problems? Childbirth. Okay. If it's any type of sexual assault, that soft tissue is prone to tearing or ripping. It would just play into a soft tissue aspect when we see that kind of compromise of the perineum. Let's get to the picture. Okay, so we have got the internal aspects of the genitalia for the female. This is going to be the reproductive aspect. Okay, so this is going to be the front view of the reproduction system inside the female. All right, so bilaterally, you can live without both or without one ovary, but usually bilaterally in the lower quadrants, females have ovaries. These store eggs, all right? Females are born with every single egg they will ever have in their life. That we differ from males in a sense that we don't constantly reproduce eggs throughout our life. That is why females go through what that males don't. Menopause. All right, so once females are out of every single one of those eggs, they don't get any more. There's certain hormones that aren't necessary anymore. They're no longer able to reproduce, to conceive, to carry children. That's why females usually in that late 40s, early 50s go through menopause because they run out of eggs, right? Women's reproductive organs have a shelf life. Guys, you consistently reproduce sperm pretty much until you die, so good for you, right? So normally what happens is typically each month an ovary will take turns. So let's say January, that right ovary will release an egg. February, the left ovary will release an egg. All right, so that egg travels through these connecting tubes right here called the fallopian tubes. And it comes down into the uterus right here, the cervix, and then out the vaginal opening, okay? If that egg is not met with sperm, if it is not fertilized, that egg and part of the inner lining of this kind of pathway here is shed in the form of a monthly period. Okay. If that egg is met with sperm, if it is fertilized, there are certain hormones that are released. The body picks up on those hormones and says, "Ooh, hey, we have a baby. We don't need to get rid of this egg. Let's keep it." All right. Hence why a skipped or a missed period is a very early sign of pregnancy. Okay, because the body's not going to get rid of that egg if it recognizes that there's a potential baby there. Okay. We'll get more into it in OB, but ideally in a healthy pregnancy, that fertilized egg will implant in the uterus because the uterus can do what? Get bigger as baby gets bigger. Okay. We run into problems when that egg does not fertilize or implant where it needs to implant. And I believe that's one of the big ones we're going to talk about in this chapter today. Okay. Yep. So again, everything is internal. This is kind of a cross section. The uterus is here. The cervix is kind of like a bottleneck opening, if you will, from the uterus to the vaginal canal or the vaginal opening. You've got your pubic symphysis here. You've got your bladder here, rectum there. So everything's in close proximity for the female anatomy. Right? Guys, typically around the age of 11 to 13 is usually when that puberty onsets for females, usually that first menstrual cycle they get. Does anybody know what that's called? It has a particular name. Menarche. I'm not going to ask how you know that, but menarche is the typical name or the technical name of that very first period that female will get. Usually this is around the age of 11 to 13 because this is happening earlier and earlier these days. All right, there has been the youngest I have come in contact is usually either 9 or 10 and she has started her period. All right, again, I'm not organic. I'm not all holistic hippie. I eat junk food. I eat all sorts of bad stuff that you're not supposed to eat. But they're coming to find that a lot of the reason that these females are starting puberty earlier and earlier, all these injected hormones in the foods, that's become a standard thing these days, and that triggers puberty at an earlier age. So what's something we need to keep in mind? What usually accompanies that puberty stage with females? Ladies, breast development, all right, any type of underarm hair, any type of pubic hair. If we see any of these in a patient, even if it's a questionably young age, it is an appropriate question to ask if this patient has received their period yet, all right? Because if they have started their period, they are technically in what age? Childbearing age. It's not a fun thing to think about for one reason or another if you've got a 10-year-old who's pregnant. But any woman, any female who has started that menstruation cycle is technically eligible to become pregnant. So if it's a nausea, vomiting, fatigue, headache, abdominal pain, any type of vaginal bleeding, we've got to establish, is there any possibility that this female patient could be pregnant? Because these symptoms could be related to a pregnancy issue. Guys, go back to that therapeutic communication chapter, have some common sense. Probably not going to be something that these minor patients are going to be like boasting in front of their parents or their friends, right? So try the best that you can to separate these patients from family members, friends, to have that, that small window that we can be honest and try to get some answers, okay? Just remember your legality, the minor, the emancipated minor, all that stuff when it comes to this. Oh, because it's up there. That's why you know that. Okay. Dun, 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 dun. Okay. So, do not get me started as to why this is the chapter that we talk about STDs, because everyone knows females are the only patients who are prone to getting STDs. Obviously. So we're going to go over the STDs or the STIs. We're moving away from sexually transmitted diseases to labeling them as sexually transmitted infections, because disease has a taboo stigma to it. Okay, so if you hear that's going to be a newer labeling of STDs and STI, it's the same thing, it's just kind of changing names. So PID, all right, this is particularly to females. What does PID stand for? Okay, pelvic inflammatory disease. So this typically happens if there's any type of like vaginal infection or anything like that that doesn't get recognized, it doesn't get treated, and it travels up more internally to get to the uterus, the ovaries, the fallopian tubes. Typically, this is going to be in a patient who is sexually active because of the introduction of possible cross-contamination with bacteria when it comes to things like that. Lower abdominal pain, guys, there is a particular, we call it the PID shuffle. All right, so if we're having a patient who is walking out to you or walks to the ambulance and they're doing this, they're holding their lower abdomen and they're not really picking up their feet and walking, they're just kind of like shuffling along. Why do you think that's a common presentation with maybe something like PID or PCOS or something like that? So the actual movement and the vibration of the foot coming in contact with the ground with each step hurts. So you might see the PID shuffle when it comes to your patients. Okay, guys, if this doesn't get taken care of, if it lingers, if it's up there in the uterus and the fallopian tubes and it's causing damage, the patient might not be able to conceive and carry children because of the scar tissue, the damage to those reproductive organs. So just something to think about. Here we go. Let's talk about female-only STDs. Again, typically that PID will progress from an untreated vaginal infection or an STD that, just like those UTIs, will travel up the tract of the urinary tract, right? Will go to the bladder, then to the ureter, to the kidney. Same thing with these STDs that can lead to that PID. So chlamydia, most common STD, this is a bacteria. Unfortunately, this has, it's very asymptomatic. There's not a ton of just like in your face, hey, guess what? You've got this STD. Okay. So guys, remember when we talked about those communicable diseases and those infectious diseases that there was that incubation period we talked about? What does that mean? What's an incubation period? The time it takes for that bacteria or that virus to manifest itself in your body and start presenting itself through signs and symptoms, okay? So please keep that in mind with these STDs, all right? I am not on the train that in high school they need to preach, you know, abstinence is the only form of safe sex. That's not realistic. That's not, yeah. So just use common sense, because again, if you contract one of these STDs by having unprotected sex, you can go out and if you're continuing to have unprotected sex with different partners, you're spreading this around if you don't know that you have it. So it's just a major, massive ripple effect if you're not using common sense when it comes to, you know, sexual activity. And I'm just going to leave it at that. Bacterial vaginosis. This is a fairly common infection in females. Females, you might have heard the vagina is a what? My doctor says this all the time. It's a self-cleaning oven. Mm-hmm. All right, it is very finicky about pH levels, about acidity levels. In composition, the vagina is a higher acidity level to kind of, if there are foreign bacteria that are introduced into the vaginal opening, that acidity makes it inhabitable for that bacteria, for those viruses. So if that pH level is imbalanced, we can start to see issues with that normal kind of temperament of that environment, and we can start to see an infection occur. Again, the bacteria, there's normal bacteria, and then there's not normal bacteria when we have a mismatch of that, particularly because of the pH levels, we start to see this. Again, if this is not recognized, if it's not treated, it can progress to PID, infertility, that patient can become sterile, all that stuff. Guys, what's going to be some overall global signs and symptoms of these infections? Okay, so maybe pain during urination, particularly in who? males usually, because remember guys, you have 2-for-1 tubing. All right, so reproductive items and urine come through the urethra in the same capacity. Females, we have separate. All right, so pain during urination. What else? Some discharge, not just vaginal. If a male has an STD, you might see some discharge coming from that opening, that orifice. Sometimes maybe like an odor. But yeah, so globally with these STDs or STIs, pain with urination, discharge, odor. If it progresses to the point where it's going back up, it's following that reverse tract, we can start to see fever, signs of infection, and all of the stuff that comes with having a global infection, not feeling well, no appetite, chills, all that stuff. Gonorrhea, well, this is full of fun words, grows and multiplies rapidly in warm, moist environments. Guys, what is the genital area? Especially female. All right, so the genital area is just a ideal breeding ground for these bacteria if they are presented. Again, if it's untreated, it will follow that track. It will eventually get in the bloodstream. It can wreak havoc on ability to reproduce and possibly go into a septic state. Everybody good on STDs? Vaginal bleeding. Okay, guys, there are several different factors that go into vaginal bleeding. Some are normal, some are not normal. All right, so just a couple of examples. Periods can be either predictable, like clockwork. There are some females who they know exactly what day of the month they'll start their period. It'll last for X amount of days, and they can track it like, you know, it's very dependable. Some females don't have that. Some females will, you know, have a regularly long period. It will be irregular. They might, you know, skip a month. So there's not always you absolutely have your period start this day and end this day. So it could be maybe one of those cycles is out of whack. We could have any type of soft tissue damage or maybe internal damage secondary to trauma. All right. We could have maybe some cervical or ovarian cysts or polyps that develop. And then we could have an ectopic pregnancy or spontaneous abortion. All right, we'll get to those in just a minute. Just like we were talking about the questioning about blood for GI/GU. I have a patient who's bleeding, has blood in their stool. I want to know what color. Okay, same with this. If the patient describes any type of vaginal bleeding, I want to know a little bit more about it. All right, if it's bright red, what can I infer? This is recent. This is an active bleed. It's an active source of blood. Okay, if it's a darker red, this incident probably happened a little bit ago. It's no longer actively bleeding, and this is older blood from a more distant, maybe trauma or incident. Okay, also how much, what I want to know. How much? Okay, so just be aware that when we ask how much blood loss for vaginal bleeding, we're going to kind of compare it, and guys, you might struggle with the comparison of this, but how many sanitary pads has it soaked through? Okay, so if the patient says, oh, you know, maybe just one, not really concerned with that, right? But if they're saying I've changed it like 7 times, you know, in the past couple of hours, that's pretty significant. So we usually have that comparison to the patients about how many sanitary pads or how many pads have you soaked through. Okay. All right. All right. So, guys, this is one of the biggest things that you need to make sure you know the signs and symptoms of, because this is a life threat for mom. This is a code 1 ride back to the hospital if we suspect what we call an ectopic pregnancy. This is not good for mom. So before, when we looked at the internal components of the reproductive system, we said that on a normal basis, an ovary would release an egg, it travels through the fallopian tubes, if it's not fertilized, it exits the body, or if it is fertilized, where does it implant itself? If we've got that sperm and that egg come together and form that little zygote, that itty bitty early baby, okay, where does it normally implant? On the wall of the uterus, okay? That's normal. Why do we want that implant or that fertilized egg to implant on the uterus?
Space.
The uterus for space, right? That itty bitty microscopic egg is going to be a lot bigger. All right, the uterus is designed to accommodate for that growth. Now, for whatever reason, if we have a case where that fertilized egg is traveling through the fallopian tubes, because this is typically where it comes in contact with the sperm, all right? So if that fertilized egg is traveling through the fallopian tube, comes in contact with the sperm, it gets fertilized, and it doesn't make it all the way to the uterus, and it implants itself inside of the fallopian tube. Why is that a problem? Because those fallopian tubes only have X amount of leverage to expand and to move, okay, and it's not very much. So if that fertilized egg implants in that fallopian tube, the egg is going to get bigger, that baby's going to get bigger, the fetus is going to get bigger, and eventually the size of that egg is going to outweigh the size of the space in that fallopian tube, and that fallopian tube will rupture. Okay, so again, let's see where it is. So the bigger the embryo or the fetus, whatever you want to call it, the bigger it gets, it will eventually rupture, kind of sever the wall of the fallopian tube, and what happens then? Internal bleeding. Okay. Guys, this will typically happen around a 6 to 8 week gestation. Okay, so usually the size of that little embryonic fetus, by the time it reaches that 6 to 8 week mark, it's going to exceed the size of that fallopian tube. Okay. What's true about a 6 to 8 week mark in gestation? Okay, no, baby's not viable. So if we have a suspected ectopic pregnancy, am I concerned at all about sustaining baby? I'm just concerned about mom. All right, baby's got to make it to at least 24 to 26 weeks to have any chance of surviving outside of mom. We're way, way, way early for that here. All right, what's also an issue with the 6 to 8 week gestation mark? A lot of women don't know they're pregnant at this point. Okay, that's something we'll talk about in OB too, but if you're one of those females who has an irregular period, it might not be abnormal for you to go 6 weeks without a period, to go 8 weeks without a period. All right, so there's a lot of females who don't realize that they're pregnant at this stage. So table that. What are some signs and symptoms? If I see this in my patient that are, I'm going to think this is possibly ectopic. All right, so sudden onset, typically lower abdominal pain. Sometimes it can be just isolated to whatever side fallopian tube ruptured, but usually it's going to be dispersed bilaterally. So sudden onset of abdominal pain, lower abdominal pain. Yeah, guys, the patient is not going to feel or be aware that it's implanted in the fallopian tubes until it ruptures.
So it's kind of like an aneurysm in that regard, and that there's no real warning until it goes horribly wrong.
Yes. Oh, that's nice. All right, what else?
Distension.
Maybe some distension, yeah, because you got to think though, if we're having blood accumulating here, it's got a quick exit route, right, through the form of vaginal bleeding. All right, so versus if we have something in the abdomen, there's not really that quick egress that it can leave. So that's why we usually see the distension in the abdomen. But we've got a quick exit down here. So what kind of vaginal bleeding? Okay, so usually excessive amounts and also bright red. This is a recent occurrence. This just happened. So significant bright red bleeding, sudden onset of lower abdominal pain. Okay.
How much does something like this bleed? Is this like you're going to die if you don't go to the hospital by
Yes.
tomorrow, or
Yes.
you're going to die if you don't go to the hospital? Now?
Usually hours.
Miscarriage kind of equivalent the same?
Yep.
Yeah, but
Hmm?
miscarriage is generally.
So typically, a miscarriage is usually not a life threat because, and we'll get there, but the body knows when it's done getting rid of things in a miscarriage. With an ectopic, the body can't say, okay, well, I've gotten rid of X amount of blood. I need to patch up this hole in the fallopian tube. It can't control the blood loss during an ectopic, where it can more so in a miscarriage. If that makes any sense. There's not just like a constant open source of bleeding during a miscarriage like there is an ectopic.
Yeah, but the difference is like that topic where it's attached like a muscle artery.
Yes,
Whereas in the uterus, it's attached to, comes apart.
there's only X amount of blood from the severance of that miscarriage that can be released. So like what? Yeah.
Like it'll just stop.
So coming back to that, if a woman is 6 to 8 weeks pregnant, she might not even know that she's pregnant, right? Lower abdominal pain, bright red vaginal bleeding. If the woman has no idea she's pregnant, she could just think this is a what? Just a bad period, right? So that's why it's super important to ask questions such as what? How are we going to determine, well, could this be a bad period, or is this an ectopic pregnancy?
Sudden onset.
Okay, so maybe sudden onset might be an indication. Maybe how much blood.
Did you have sexual contact about a month or two ago?
Are you sexually active? Is there any chance that you could be pregnant? Right? If you have a patient who is like, nope, I am celibate, I am a virgin, I've never had sex, and they're telling the truth, is this a miscarriage? No. Is this an ectopic pregnancy? No. It's a bad period. All right, so we've got to establish in a tactful and professional way, is this a possible issue because the patient could possibly be pregnant? All right, so we can start out, guys. It's not inappropriate if it's relevant to our patient. Are you sexually active? All right, and if the answer is yes, what's our next question?
When?
Do you use protection? Right, whether that's the form of birth control, in a pill, in a shot, in an IUD. Did your partner use a condom? Like, we need to know, have you had unprotected sex in the past 2 months? Because if you have, I can't 100% rule out that this is not ectopic, right? So we've got to establish if it is a possibility the patient is pregnant. Okay? Yeah. So make sure, guys, if this is registering on your radar, this could possibly be ectopic. This is a code 1 right back to the hospital. All right, your patient can go into hypovolemic shock. Your patient can die. Your patient can bleed out from this. All right, my long-term partner and I and his wife got pregnant at like the same time. The way that all of this transpired is still kind of eerie. All right, she is a nurse in the ER at Grady. She was at work. She was around 8 weeks pregnant, and she started feeling some uncomfortable cramping, and she thought that, hey, this is normal, because usually in that first trimester you might have some cramping from everything kind of getting settled in and that egg really like implanting in the uterus. And then she all of a sudden just kind of like doubled over. She was having vaginal bleeding. She works in the ER, so she was like, hey, this isn't right. They actually had an ultrasound machine. They took her into one of the rooms, did an ultrasound. She had an ectopic pregnancy. Her right ovary was just completely, her fallopian tube was completely gone. They had to take her up to OR, like immediately. And she had to get like 3 liters of blood. So had she not been at work that day, like immediately in the hospital, 5 minutes away from the OR, she probably would have bled out.
3 liters of blood, yeah.
Okay, so this is a life threat for mom. We're not concerned about baby at this point. Just make sure if you're recognizing it, let's get them because they need an operating table. Okay. Guys, I don't care what the injury is. I don't care what the medical ailment is. Does anything ever waver about treating ABCs appropriately? No. Okay, so everybody's clear that nothing changes with this. If your patient's in any kind of maybe hypovolemic shock, treat for shock, manage ABCs. Everybody good with that? Okay. Yeah, so guys, you can ask if they are sexually active, if they're using protected sex, and then we can ask, it's not always reliable, the female patient, when was the last time you had a period, or when was your last cycle? Again, if the patient says, oh, it was 8 weeks ago or 2 months ago, but that's normal for me, if they have an irregular period, it's not always reliable. But if you have one of those females who is like, no, I get mine like clockwork and I hadn't had it for 2 months, then we can probably have a strong suspicion that the patient is pregnant. Again, if your patient is not having a life-threatening amount of vaginal bleeding, we are not going to expose and assess. Okay, if your patient's sitting on the stretcher or sitting on the bed and you come on scene and there's just a big pool of blood, all right, what can we do? How do we treat excessive vaginal bleeding to the point where we're concerned about hypovolemic shock? Externally. All right. So you will get a big trauma dressing. They're like abdominal pad trauma dressings, fold it up and just make like a makeshift diaper, if you will, or a makeshift sanitary pad, if you will, for the female. For the love of Pete, make sure everyone's clear on this. You do not insert anything into a female or a male patient's genitalia. Even if you're attempting to control bleeding, we control all bleeding externally. Everybody clear on that?
Yeah.
Okay. I know, but I do. We control bleeding externally. Has that been done that I have to say that? Way too often. And it's not out of like anything malicious, but it's usually male patients who don't deal with that on a normal basis, and they just like, yeah, let's just
shove it in there.
Externally. Control vaginal bleeding externally. Whether it's trauma, whether it's a medical etiology, technically this is trauma, but you know what I mean. Childbirth complications, all female genitalia bleeding is controlled externally. Everybody good? Okay. Sexual assault. Unfortunately, this is a thing. This is something that you're going to come in contact with. And again, it really irritates me that this is only thrown into the gyno chapter. It's insinuating that females are the only patients or the only sex who's vulnerable to sexual assault. And guys, that's not true. All right. We live in Atlanta is a very heavy LGBTQ. I hate that's not coming. No, they added there's another. Is it IA? It is a lot, but we need to be all inclusive. Okay. And there are a lot of sexual assaults that occur on patients who are not female. So do not think that just because your patient is male that they have not been sexually assaulted. All right. Not true. Ran that call. Just gonna put that out there. Just irritates me that they clump this together. Again, 1 in 4 women, 1 in 5 women. It's males too. Everybody good with that concept?
I think the percentages are just one.
I would venture to say, especially here in Atlanta, because of that big community we have, it's not far off. Yeah. Okay. So guys, any kind of sexual assault, what's a concern for us as medical providers? If we can, injuries, soft tissue trauma, blood loss, all right, that's going to be our major concern. Most of the time we don't deal with excessive blood loss to the point where I'm concerned of hypovolemic shock. It doesn't happen. But what other factors go into treating a patient of sexual assault? Yeah, guys, the way you interact with them. The mental trauma is much more significant usually than the physical trauma when it comes to stuff like this. All right, so what are some things we might want to take into consideration, or how we might change our approach to patients who are victims of sexual assault?
Like being more respectful.
Let's start off with not judging them. Exactly. That should be the mindset of everybody, but it's not. Well, this happened because you put yourself in a position for this to happen. You deserve this.
If you're in a 2-sex team, have the partner who's not male or male or female, depending on who the victim is.
Okay, we're gonna come back to that. Absolutely. Yeah. Do not cast any judgment on your patient because they just got sexually assaulted. Are you kidding me? No. People don't ask for that to happen. Okay. But yeah, depending on the sex of the patient, we do need to keep in mind maybe who the sex of the assailant was. But if it caters to this particular situation, if you're a double female truck and you have okay, so let's do if you're a double male truck and you have a female who was just sexually assaulted by another male, you might want to get on the phone with supervision and say, hey, do we have any female crews that could come take this call? It's within your scope if it's soft tissue injury, right? You can handle that, but if it's available, but try to get a female, like a same-sex partner and patient, because it's very possible that if that person was just assaulted by a male, that they're going to want a male like touching her and asking her questions and being in her personal space. Probably not. Okay, so just keep that in mind. What else?
Announce all your actions, like if you're taking their vitals, and let them know.
Yeah.
Hey, can I get your blood pressure or something?
Yeah, any kind of physical touch, even just like coming close up to that person's body. They might not be fully registering what is going on with them, and if they feel just out of nowhere somebody touch them and grab them, think about what they just went through. Probably not going to go over well.
Basically bring psycho into this.
Yeah, to a certain extent, yeah. Okay, I mean, you should approach every single patient introducing yourself. You should tell every patient before you grab their arm and take a blood pressure, hey man, you mind if I do this, you mind if I do that? But just keep in mind that this is, usually very fresh after the fact that this happens. So keep in mind your movements and your physical interaction with these patients. Again, like these depressed patients or the suicidal patients, if you can't relate to them, don't try. If you have never been through anything like this patient has been through, don't say you understand, because you don't. Don't expect to fix them, right? Don't expect to be Dr. Phil and say these kind and comforting words and then, oh, okay, thank you for saying that. It doesn't change the fact that I just got raped, but it makes me feel better. Don't expect that. You can try. You can be, compassionate and try to talk to your patient, but just don't expect it to, fix the situation. All right, so kind of going back on what Andy said, what about evidence preservation? What are we there for? Patient care, all right? Remember that when you're going into your documentation, it doesn't need to read like a police report. Whether it's a sexual assault, whether it's a domestic dispute, a GSW, a stabbing, whatever it is, it doesn't need to read like a police report. If your patient confides any pertinent information to you, that's okay. You can include that, but don't be like, who did this to you? What did they look like? You know, did you know the person type thing? Like, we're not trying to. Well, if it is dispatched as something like this, typically PD co-responds. So if PD is on scene and the patient's maybe, you know, giving this information,
So you can
that could be something we relay to PD, unless the patient tells you not to. All right, but if the patient is freely giving you this information, maybe they feel more comfortable talking to you than they do PD, you can relay that information and let PD do their job with that information, right? What are some things that we can do that's not really going to compromise patient care that can try to preserve evidence, but we're not overstepping our boundaries going into like police work? Discourage them from what? Yeah. What? Huh? No. So yeah, guys, this is something I cannot personally relate to. I couldn't imagine, but a lot of patients will want to like remove any type of physical remains of what happened. So taking a bath, getting a shower. All right. If that physical reminder is not there, maybe it helps them forget. But what are they washing away? Evidence, DNA. Okay. So discourage the patient from taking a shower, taking a bath, doing any type of excessive cleaning, because that, you know, can be used to bring whoever did this to justice. What else can we discourage? What about changing their clothes? So kind of the same concept of, you know, avoiding cleaning themselves. There's going to be evidence in the form of DNA on the clothes if that's what they were wearing when the assault happened. All right, so try to keep them in the same clothing. If, you know, for whatever reason, guys, if PD's not on scene and our patient says, yeah, those are the clothes, I changed, those are the clothes there, we can bring those with us, right? Because what happens at the hospital? What should happen at the hospital? Rape kit. Okay, so that's their job to collect that evidence, to collect that DNA. It's not our job to absolutely 110% preserve it, but we can do little things to try to help that stuff stay intact. Okay. Also be aware, date rape drugs. Guys, if you've got a patient who's been sexually assaulted, let's not, you know, immediately rule out that there might not be drugs in that patient's system. If they're altered, it could be because they were drugged in, you know, attempts to have the rape occur. So we would treat those signs and symptoms of that drug the same as we would whether or not there was a sexual assault. Okay. Questions, comments? All right, so guys, with this, just like those patients who were, you know, depressed or having suicidal ideations, we can probably get the vibes if the patient wants to talk to you about what just happened or not, or like how they're feeling or not. So if they're not wanting to talk, you need to say something along the lines of, hey, I understand you just want to be by yourself right now. I have a few questions I have to ask, get a couple vital signs, and once we deal with that, I'll leave you be. Right? Let them know that you're not just going to sit there and pester them the whole time, but there are some baseline things that we need to get information on. Okay. Got to talk about it. If there is an object that is inserted into an orifice, whether it is rectal or vaginal, Do not attempt to remove it. Leave it in place, position the patient appropriately for if there is an object that is protruding, but that needs to be done in a more controlled setting. Who knows if it's, has compromised an artery and the object still in there is putting pressure up against the artery. If you remove it, we can cause more damage, all that stuff. So don't remove anything if it is placed. What an uplifting subject to end this chapter on, right?
Yeah.
Questions, comments, concerns? Yes.
With respect to reporting, it's ultimately up to the patient unless they're right.
So yeah, guys, remember we are mandatory reporters, or mandated reporters. So if the patient is an adult, they don't have any issues going on that would not allow them to make their medical decisions for themselves. If your patient tells you this X person did it, but then tells you, I don't want the cops involved, you have to go with what that patient says. You can't behind that patient's back call PD and say, hey, meet us at the hospital, need to report, sexual assault. If the patient is within sound mind, makes their own decisions, and they're an adult, you're stuck between a rock and a hard place, but you got to go by what the patient says. Now, if the patient's a minor, if the patient has any disabilities that they need care from anyone else, right? Like if they can't provide care for themselves, then absolutely, that's a mandated report for sure. We would get PD involved, we would get our supervisor in the loop, and we would pass that on during our verbal report at the hospital. Because guys, I have run into patients who have been sexually assaulted that don't want to press charges. It's frustrating on our end, right? But we're not in that patient's shoes. We don't understand the dynamics as to what's going on. You can't press it. Okay? Yes.
Also in that vein, so if they're older, so if they were obviously drunk and they say they don't want to, would you still do that in place because they're how?
That's kind of a sticky situation. I would get PD involved when that patient comes around and those drugs wear off. If they're adamant, once PD is kind of tied to the case, if they say, no, I don't want to pursue this any further, I'm not telling you anything, then what's PD going to do? Okay, we're done here. So if they're altered, if they're drugs, then yeah, then definitely we need to get them involved, and then it'll be up to the longevity to see if it goes through. Okay. Everybody good? Okay. Everybody good in Zoom? Cool.